Well, good morning, everybody. Hope you enjoyed the hike commute this morning. Just delightful, an hour and 40 minutes or so to get from that place in the Weston Tolls that normally gets us here in 20 minutes. So, Jacob, now I think you understand why it is that Doug Fridsma says Postel's law is so important. Postel's law is the idea that you send using very specified standards, but receive anything. So, welcome to Plugs in China. So most of my day is actually spent on the kinds of things that the federal government has outlined as the important 5-year program for meaningful use, ICD-10, HIPAA Omnibus Rule, and ACA. And Micah asked me to talk about things outside this 5-year plan. Kind of challenging. I mean, this is pretty important work. I mean, Susan, I don't know if you read over the weekend, there were 2 critical injuries that occurred. One in North Carolina, a gentleman was driving a lawn tractor and was hit by an airplane. And one in New York, a gentleman lost his upper extremity in a pasta machine. I did check, there are ICD-10 codes for both. So we know that ICD-10 has been delayed, but nonetheless, there is work on ICD-10 that continues in all of our communities because we've invested billions of dollars as a country, and we need to try to capture that value. And as Jacob outlined, there's important efforts to measure quality. There is the Meaningful Use Program, which continues, Stage 2 now, Stage 3 in 2017, and a whole variety of Affordable Care Act-related activities that require big data analytics, that require care management and population health. IT departments have been saturated to the point where, in some ways, our agenda is no longer our own. But yet it is important over the next couple of years to squeeze in innovation despite this roadmap. So how do I think we should do that? Now, you've probably heard the SMAC acronym of Social, Mobile, Analytics, and Cloud, and I realize this could be a peak of a Gartner hype curve, but let me talk about the reality of social, mobile, analytics, and cloud in the context of all the work we're doing as a country. So the comment was made both by Jacob and the questioner about the usability of EHRs. How do you get through your day, given that you have 861 data elements to capture on 44 quality measures while not committing malpractice, having patient and family engagement, and ensuring that the patient is actually getting your full attention? Very hard. What if, instead of the doctor taking 12 minutes to do all those things, a team-based approach where the right person did the right work? We have nurses, PAs, social workers, pharmacists. We all contribute to the patient's record and the patient's experience in a Wikipedia-like fashion. Now, I don't really mean Wikipedia, but you get my drift. What is Wikipedia? It is the idea that many people create wisdom of the crowd, and the end result is approved by an editor and then curated over time. Well, what if meaningful use was team-based documentation? So, Jacob, I asked my friends at CMS, so how do they feel about having 27 people author a note? They said, not so great. So I asked the following question. What if we have 27 people in a place outside the medical record create a representation of what they thought was important about the patient's visit, the patient's lifestyle, activities of daily living, patient needs, including the patient, and then a clinician, one, published that document, signing it and taking accountability for its contents, and they said, that's fine. So as we try to achieve meaningful use as a country, what I would hope, because I am one of these doctors suffering like many of you have suffered, that we start really breaking the paradigm of one EHR, one doctor, lots of clicks, and we start moving to a social media team-based approach to documentation. Really important that we share everything we write with everyone on the team, including the patient. So for the last 3 years, we've shared everything about you with you at Beth Israel Deaconess, and admittedly, sometimes there's some awkward information shared. So if Jacob were, for example, while driving in Boston, to suffer great anxiety because our traffic is horrible, and come to the emergency department hyperventilating, I might say, Jacob came to the emergency department with SOB. Now, I know that means shortness of breath. He may think it's the person he came to the emergency department with. So sharing a note does require that we reflect on what we're writing and that it'll be shared broadly. It's a little bit different approach than we've used in the past with abbreviations and shorthand. But it's worked really, really well at Beth Israel Deaconess, Kaiser, and other places that have tried it. I'm going to show you a couple of quick examples. My father died about a year and a month ago, and he was in an ICU in Los Angeles. And I went into that ICU and asked the pulmonary fellow, how's my father doing? And the pulmonary fellow said, his O2 sat is 88%. Asked the renal fellow, how's he doing? And the renal fellow said, his creatinine is 3. Asked the cardiology fellow how he's doing, and I was told his ejection fraction is 20%. Now, no one could actually tell me how my father was doing. Now, isn't it better if we, in emergency departments or ICU settings, turned our data into wisdom that the patients and families could understand and act on? I'll show you in just a moment some examples there of what we're doing to create patient and family dashboards that accomplish that. And I certainly think important as we look at the Affordable Care Act and what Jacob described as continuous wellness, that we start engaging patients in their homes, gathering data from their Fitbit, but also interacting with them using teleservices. Do we really want people driving an hour and 40 minutes down the pike to get to downtown medical care by expensive Harvard professors? No. We want them to stay in their homes and receive remote visits as indicated based on telemetry we're getting from them. Another quick example. So my father had MS for 23 years. I didn't know that every time I visited, he bolused steroids 24 hours before my visit to mask all of his symptoms. Now, what if Fitbit data, or hey, could have been Angry Birds, which actually does monitor your movements, were able to be put into a personal health record or a medical record where I would be able to discover he moved 5 feet a day, except on the days that I visited where he moved 5,000 feet a day. Interventions, teleservices, new services would have been possible. So, quick examples. Our problem list at Beth Israel Deaconess is a social problem list where every member of the care team adds, subtracts, deletes, and modifies problems. So it's truly a community-curated record of your problems and issues. Same thing is true about our medication list. Every time you have an encounter, inpatient, outpatient, emergency department, anyone in the community can describe how you're actually taking your medicines. Knowing that you may not take them as prescribed, you may not have been compliant, you may not have filled them. We may not even know the dose of some or how you're taking it, and we reflect that. Here's some examples in our ICU of trying to create social software principles. Now, we know that there are things about an environment in an ICU that can be inherently risky. What if it turns out the ICU is a little overloaded? Lots of input, lots of output, lots of change. What if the usual nursing staff is on vacation and there are travelers in the ICU? What if bed 1, 2, and 3 are all getting procedures at the same time? These are all risky states. So this dashboard, now in pilot, shows across the environment of the ICU how safe is the place at the moment. This dashboard is used more by providers, nurses, doctors, administrators, people who are coming in and out of the ICU. The one that's used by the patient looks like this. So why are you here? What are the things that are likely to happen to you today? What are the care plans overall? As patient and family members, what level of involvement do you want in the care of this patient? Do you actually want to be there every time there's rounding activity? Do you want to be there when there are any changes in condition? Do you want email, SMS, or other communications around the care and care changes of this patient? This is the kind of thing that didn't exist for my father. And you can have interactivity where you, for example, say, I want a family meeting. I want to get the caregivers together and work on the care plan. And then for the providers as well, higher level dashboards onto how is the patient really doing overall per care plan and goals. Try to turn that data we have into wisdom. Mobile. So we're spending all these years creating electronic health records, getting structured data, very, very important for quality measurement. But, at Beth Israel Deaconess, the current form factor of the emergency department medical record is that. So what happens? I walk into the emergency department. I log in to a secure portal. I've identified that I am a rightful doctor in a rightful place wearing a device that is registered on the emergency department wireless network. After I log in, a QR code appears. I scan the QR code by looking at it. I've authorized to get the emergency department record. In every room, there is a QR code on the wall. As I walk into the room, the Google Glass recognizes where I am and therefore who is the patient in front of me and shows me the problem list, medication list, current orders, and telemetry of the patient in front of me. We've used this since December and had many lives saved. As an example, a patient comes in extremis. Absolutely no understanding of who this patient is, what the patient's issues are. 2 minutes after the patient arrives, the patient's wife arrives, a registration activity occurs. Instantly we know who the patient is. The doctor who's doing the resuscitation instantly sees the data about the patient he's resuscitating. In this particular case, the doctor had a syringe of medication and was about to push it when on Google Glass, allergy to this medication appears and the life is saved by not giving a medication that would have caused harm. And the patient ended up doing fine. So there we go. So I would think that as we do meaningful use, good, but there are workflows and innovations like using wearable computing that we hope along the way are going to be possible. And I just put up, Jacob, this term, BYOG, is bring your own glass. It's the next trend. We've got 5 of these being used in the emergency department by 10 docs now. This just shows you an example of Dr. Stephen Hornig, who was one of the innovators creating this, and what the doctor actually sees: active problem list, medication information, radiology x-ray information, and care plans and those sorts of things. So analytics. I have 3 petabytes of data. I actually don't think big data is big anymore. I actually don't have a problem curating, storing, keeping safe 3 petabytes of data. My problem is producing actionable wisdom from that data. And so what you're seeing, especially if you went to HIMSS, is lots and lots of companies offering care management, population health, and business intelligence. I don't know about you, but I found most of the vendors had written their software in PowerPoint. It's a powerful development language, very easy to change. So we've had to rethink just the EHR as the data collection tool, and as Jacob commented, it's how do I present to the clinician at the point of care information about what needs to be done now based on data I've aggregated about the patient? How do I incorporate external sources of data, patient-generated data, genomics data, into that, and then provide a meaningful intervention? So let me just give you a couple of examples. I realize this is a classic IT slide, lots of lightning bolts, clouds, can't possibly read it. This is how hard it is to take data from 5 different EHRs that exist in our community, normalize that data, and put it into a single framework so that we can look at gaps in care, look at guidelines, protocols, where is the patient appropriately going to receive certain services, where have not they received services, what can we do to keep them out of the hospital and out of the emergency department. In this era of global capitated risk, it's getting, fee-for-service is dying, what we want to do is actually not spend money. Redundancy and waste is bad. We actually don't want you in the ICU. So we create this centralized infrastructure, and sometimes you centralize data, as I'll show you, sometimes we federate. so that we can have our care managers, our non-physician extenders, figure out in the community what care the patient needs, so that we actually can look at that congestive heart failure patient who keeps bouncing back and figure out how to keep them in their home by doing visits, home care, or teleservices. Sometimes we federate data. So another personal example. My wife was diagnosed with stage 3A breast cancer that was HER2 negative, progesterone positive, estrogen positive in December of 2011. Interesting to her and interesting to me, of the last 50,000 patients who had this kind of breast cancer, how were they treated? What were their outcomes? Are there things that we should either choose or avoid? Are there side effects we should know about? This happens to be a piece of open source software that we've used across all the Harvard hospitals called I2B2. You can download it at i2b2.org. And I asked the question, show me for this diagnosis, this treatment, what's the numerator, what's the denominator, what were the outcomes? Our IRBs, Institutional Review Boards, allow any employee of Beth Israel Deaconess, and the same is true in other hospitals, to use this tool without specific research approval because we're not disclosing any patient-identified information. These are numerators and denominators. If the answer is, of all women treated with this breast cancer with Taxol and adriamycin and Cytoxan, there was 100% recovery, doesn't say who, it just says what. So this particular tool allows us to mine 5 million patient records, is non-disclosing, and certainly helps us guide care based on historical experience. So cloud. Sometimes clinicians and the CIOs are reluctant to adopt cloud technologies for fear of privacy concerns. It's an interesting time in history. At the time we're trying to do more electronic records for more people and measure quality and innovate, the Office of Civil Rights, the Attorney General, the OIG is doing more audits and giving more fines for the breach of medical records. You may have saw last week that $2 million of fines came out of OCR for 2 lost laptops. So sure, in that environment, cloud is a hard consideration. But what we figured out is that clinicians in the Massachusetts area, first, don't have a lot of time, don't have a lot of money, certainly don't have the expertise to keep servers in their offices, and they really are mobile people. They want to get at the electronic health record in the office, in the hospital, in the nursing home, and while off on vacation. So we've done our own private clouds over the last couple of years, and that has worked really well. And we're asking the question, given that we have been able to offer services at low cost, as well as keep data secure, might we want to consider moving to public cloud offerings of electronic health records? As we go forward the next couple of years, that is a serious consideration. You may not know, but all of the Centers for Disease Control syndromic surveillance data is stored on Amazon. That's right, Amazon's GovCloud hosts all CDC data. I do 4,000 data transmissions per day to Amazon on behalf of the CDC, and that data is kept completely secure and is used by CDC and state health departments to look for trends in diseases. One of the things that the folks at ONC have thought about over the last year to two is the learning healthcare system. IOM wrote a report on that. How is it that we could imagine, whether you come to Beth Israel Deaconess or go to the Mass General or go to the University of California, San Francisco, that you actually get the same treatment based on evidence rather than anecdote or apprenticeship? Because all of us as doctors were trained as apprentices. We've practiced totally differently. So a couple of years ago, we created a cloud-hosted decision support system that enables clinicians ordering radiology tests to place things like, okay, I have a 450-pound patient who is allergic to contrast material, is claustrophobic, and has a pacemaker. What imaging study should I order for abdominal pain? And the answer is based on evidence. There are choices, some safe, some non-safe, some effective, not effective. These are the kinds of things we should see over time developing so that every EHR in America can get knowledge from a single curated best practice set of guidelines. You may have seen in the Boston Globe that last week there was an attack on several networks in the Boston area. A number of the hospitals have used third-party experts and cloud-hosted security services to keep our medical records and our networks safe. So I show you all this to say, although there is reluctance to use the cloud in medicine, it is becoming more reality, and there are many systems already in production. But of course, there are concerns. When we talk about social, mobile, analytics, and cloud, there are federal and state privacy laws. We must be very sensitive to patient preference for how their data is shared and who it is shared with. So Massachusetts, as a state, has opt-in consent. We won't share data about you unless you give us permission to do so. There are FDA issues, and the recent FDASIA report I thought was extraordinarily well balanced. It basically said, imagine that, I don't know, on my iPhone, it tells me, CVS Pharmacy recommends that I push this button to get a renewal of my prescription. Okay, don't need to regulate that. That's more of an administrative transaction on an app. Or how about this? It measured how many steps that I took today, and it recommends I don't have cheesecake tonight for dessert. Okay, that's more of a wellness app. Well, how about this? It looks at my face and says, you look pale today. I think your hematocrit is low. Go take these 5 meds. That should probably be regulated. So FDASIA basically says, wellness administrative, no worries. Medical device, absolutely, you need regulation. So we need to be sensitive to that. And in that context, this is not an FDA-regulated device because it is purely a pass-through of data that is stored on Beth Israel Deaconess servers in the emergency department. I don't know about you, but my doctors have exactly 0 tolerance for downtime. I tell them I will offer them 4 nines reliability, and they say, you mean we'll be down 8 minutes a year? You know, what are you doing those 8 minutes a year? You sleeping? And so they actually, whenever we do even have planned downtime, and it's truly minutes a year, I get emails, harm to my patients will occur if you ever take the systems down. So increasingly, we have to innovate, ensure we meet all federal regulations, provide perfect security while providing perfect reliability and stability. And this is a bit like changing the wings on a 747 while it's flying. So life as a CIO, never boring. This is why I own a farm. I go home and I shovel manure. Very different than my day job. So I'll summarize. I believe that while we're doing meaningful use, ICD-10, HIPAA Omnibus Rule, and ACA, we need to embrace social constructs, and those are compatible with the federal regulatory goals. In fact, can make lives easier for all caregivers. I think the desktop is going away. If you haven't already migrated to an iPad mini, that's just a step on the way to wearable computing. I don't think big data is big. We just need better tools to analyze it. And I've been charged over the next couple of years with rethinking the IT department as mergers and acquisitions help in healthcare. My thought is to blow up the IT department completely and to just rename it the Cloud Services Department. And we offer a series of both provisioned services and acquired services. We are enablers of cloud services. Basically, we are the care traffic controllers of sorts. And finally, because all of us are pretty overstressed, I would say if I look at my position on a day-to-day basis, I get depressed because things need to be done that aren't yet done. But look at where we've come over the last 4 years. I think it's true my daughter, who's now 21, will not experience medical care in her lifetime in the paper-based scrawl that you described. She will be supported by a fully electronic record. So the road the last couple of years was hard. The road the next couple of years will be hard, but our trajectory is good. So Susan, turn it back to you. Thank you.